just gone a little after 10 o'clock. It's just gone after 10 o'clock, and that's our starting time. And it really is a special joy to be here in this beautiful brick building. It looks absolutely amazing on this sunny morning. And it's even more special because I think, if I'm not mistaken, this is a very, very first meeting of JHOSC in this building here in London Borough of Hillingdon. So, Nick, I am absolutely excited to be here this morning, and thank you very much for agreeing to host us this morning. And can I, as is our tradition, can I please invite you to say a few words of welcome? Thank you.
So, welcome everybody to the end of the JHOSC line, which is Hillingdon, and welcome to our building, which was built in the early 1980s, won lots of awards, is listed, but I feel like actually is what people in the early 1980s thought the future would be like. So it's suddenly become very retro. So it's an absolutely beautiful building, but you get completely lost within it. So I hope that isn't a metaphor for today's meeting. But anyway, welcome to everybody who's come today. It's so lovely to see everyone. And thanks, Ketan, for letting me say a few words.
Thank you very much, Nick, for those really warm welcome. And we are also joined by the Chief Executive's representative, Sandra Taylor, who is the director for, I'm going to get this wrong, but hopefully not, adult social care. Thank you very much. I hope I've got that right, Sandra, but it really is good to see you. And if you could also say a few words, it would be really good to hear your words of welcome.
Good morning, everyone. Yes, I'm here representing Tony Zaman, the Chief Executive today, who is attending his daughter's graduation, so I think that's okay for him not to be here today. Is it interesting that Councillor Dennis notes about the building? My funny story to this building is that I came here on a school trip when I was doing my business studies to see what a modern office looks like.
Wow.
So, a few years ago, obviously, but welcome everybody. Thank you for coming to Hillingdon. It's really good to see people in person and faces, and put names to faces, and enjoy your first meeting in Hillingdon.
Thank you very much indeed, Sandra. I really am grateful to you. I know you have a very busy array of meetings this morning, so if you need to leave early, then that is absolutely okay. Thank you very much. So, colleagues, before we come to the main business of our meeting this morning, I'm going to pass you to my colleague Nikki for some administrative work, which hopefully shouldn't last too long. Nikki, please.
Thank you. The first item, or the first item I need to deal with on the agenda is the election of chair. Do I have any nominations?
Of course, yes. I would like to nominate Councillor Ketan, please.
Is that seconded?
Seconded.
Are there any other nominations? Okay then, Councillor Sheff is elected as chairman. Thank you.
Thank you very much indeed. Good committee. It really is a great honour and privilege to be chairing this hugely important meeting. A hugely important scrutiny committee with a very wide geography, and I couldn't be more prouder to be leading this committee. Thank you very much indeed, and really I'm looking forward to another exciting year ahead of us. And at the back of our papers we have even exciting work programs, so looking forward to all of your contributions in coming days and weeks and months. Thank you very much. So we return back to our agenda items. So we return back to our agenda item, and so the next bit of administrative business we need to conclude or deal with is the election of vice chair, please. And can I nominate Councillor Natalia Purvis, please? Are there any seconder, please? Chetna. Thank you very much for that. Are there any other nominations? So with that, Natalia is duly elected as Vice Chair, and on behalf of everybody here, many, many congratulations. And can I also, at this particular moment, pay a huge tribute to our previous Vice Chair, Councillor Dan Crawford from London Borough of Ealing. He was a member of this committee for many, many years, and I think at every single meeting he came, not just in person, but he came with huge bag full of passion, and I think the passion was the hallmark of who he was as an individual, and I think his contribution was very much appreciated by me, of course, but the entire committee, but I think much more widely by our residents, not just in London Borough of Ealing, but throughout our geography. So huge thanks to Councillor Dan Crawford, and I'm sure when I say huge congratulations to him, I'm speaking on behalf of all of us as well. So thank you very much to Councillor Dan Crawford for years and years of outstanding public service, particularly this committee. So now let's just go back to the original numbering of this meeting. Apologies, please, Nikki.
Chairman, I don't think we've had any apologies from members.
Thank you very much. So then, declarations of interest, please. So let me start with mine first. So I am the lead governor of Central and Northwest London NHS Foundation Trust. Any other declarations, please? Yes, Ben.
Just for transparency, my day job is I'm employed by the Nursing and Midwifery Council.
And while I've got you on the loudspeaker, let me just congratulate you, Ben, on your appointment as the new member for London Borough of Ealing. Really, we are all really grateful to have you, and really excited at the same time, and looking forward to having your contributions in coming meetings. Thank you very much. Any other declarations? Very well. Thank you very much. Nikki, I'm not aware of any deputations. Thank you. And so the next item is minutes, which was held at Ealing Town Hall. And thanks to Ben. Please do pass on our thanks to them again. Shall we just take those minutes as tabled? Thank you very much. Any matters arising which is not elsewhere? Thank you. So then we come to the next substantive item, or the first substantive item, which is the North West London strategy for provision of acute beds. And unfortunately, some of our NHS colleagues are not able to join us this morning, but we are grateful that Bob has been able to join us, and I think this is your first meeting, so very welcome to this amazing location. And if you could spend, we do have the paper in front of us, but if you could spend a few minutes just picking out the key highlights for us, please.
And thank you very much for the very warm welcome, and it's lovely to be here. Rob Hurd is up on screen, and I think we're going to do a bit of a double act. So Rob, who is the Chief Executive of the Integrated Care Board, and I'm the Director of Strategy at Imperial College Healthcare, very involved in them, and I think it would make the most sense for Rob to start in the first half and then me the second half, if that's okay.
Rob Hurd is no stranger to this committee. He's a great friend of this committee. It's always a pleasure to have you, Rob. Very welcome. It would have been even more of a pleasure to have you in the room, but unfortunately we are having to do with you on the screen, but nonetheless it's good to have you. So very welcome, good morning, and if we can have the key headlines to begin with, and then we'll return back to Bob.
Thank you, Chair. And yes, let me start with an apology. In my 18 months, I've been physically present at every single joint health overview and scrutiny committee thus far. The irony being, on every other Tuesday, I do spend in Hillingdon, and this is no exception. But today, because of a clash with our board, I couldn't make the geography work. So can I start with a formal apology for the lack of physical presence for the first time in the Joint Health Overview and Scrutiny Committee in my tenure, and it is not something I would intend to repeat as a matter of course, but there were unavoidable circumstances, so my apologies. On the specific item, first item on the agenda, you asked in the context, particularly of some of the recent decisions around the new hospital programme nationally, a revisit of our North West London strategy for the provision of acute beds, and I'm not going to go through the paper in detail, but I just to signal from the outset, in terms of NHS North West London, before handing over to Bob, I want to just do a few sort of context points here. The prevention, keeping people out of hospital services, the admission avoidance, packages of care out of hospital, appropriate care settings, and care for patients in their home, in community settings closer to home, is the objective of all of us, and to get the most of rather than building bigger and bigger hospitals for inappropriate stays in hospital. We have to reduce the number of patients not meeting the criteria to reside in our acute hospitals, and we have to get maximum impact from the £5 billion that we spend, and indeed the additional funding that is targeted towards the avoidance of unnecessary and avoidable hospital inpatient stays. To do that, we're going to follow the evidence, and we have and the paper outlines some of the background in terms of how we're following the evidence and the most appropriate models of care, understand the impact of what works, and what we are trying to do to support residents and patients through acute hospital services. And the number of beds is a measurable, tangible thing that we acknowledge is important for the scale of capacity, but there are many measures of outcomes, many measures of that point to the inequalities of outcomes of health and care services. And it's important to take that all in the round. What the paper is trying to do is give the acute bed lens to a bigger picture of where we are. So the table gives the specific numbers. There are definitional issues of what is an acute bed and how we measure those things. We've had ongoing discussions around the mental health bedded capacity and where we are with the strategy on that, and that's not the purpose of this specific item. But I think the overall strategy is not to continually increase acute bedded capacity on the patch, because that would be not in line with ensuring that patients are best treated in the best setting with the best evidence base for health and care outcomes, and that we have a variation across the year in how we, in particular pressure points, seasonality, winter pressures, etc. We do increase bedded capacity to respond to demand pressures, but that is finally also to say that, with this by way of intro into the new hospital programme, that which bedded capacity does exist and we continue to support, there remains major challenges in the quality of that capacity, and Imperial is no exception in that, as high on the risk radar of the system within that, and how we are managing that, albeit at the Hillingdon, the approval to progress with the Hillingdon Hospital rebuild is obviously a cause for celebration, and to be getting on with that. But I won't steal Bob's thunder on getting into that element of it, but that's
Thank you.
those headlines, Chair, on the sort of context for where our overall strategy is on it.
Thank you.
In line with the paper as a context for that particular news around the new hospital programme that took place last month. Thank you.
Thank you very much for that, Rob. Grateful to you. Bob, please.
Great. Thank you very much, and good morning to everybody. As I say, my name's Bob Claber. I'm a paediatrician. I'm the Director of Strategy, Research and Innovation. Apologies from my CEO, Professor Tim Orchard, who I know you all know. There again is a sort of a board clash, but I'm a very willing attendee, and it's really lovely to have the warm welcome and understand a little bit about the building, and clearly on a very busy historical week for you all as well. Picking up really from Rob, I've been very close to the Imperial College Healthcare work around new hospitals. which and also have some sight of the work at Hillingdon, and I think important for members to note that we work very closely, and there's been lots of really good shared learning with the teams as we are dealing with the new hospital programme, the Department of Health and Social Care and government to try and get through what is a really complex set of arguments. I very much would agree with Rob's presentation on it. I'd highlight to members a really important piece that I think the paediatrician in me has really rammed home very heavily is we can't just talk about demand and capacity. There's a word that goes in front of it, and that is need. So we need to think about need and demand and capacity. And our relationship with your colleagues in the local authorities, particularly the directors of public health, are very, very key on that, because we have to build hospitals for the future that are the right size. As Rob has alluded to, we need to make sure that the models of care are right, but we have significant health inequalities in North West London, and the only way we're going to tackle that is if we properly understand need. So the work to understand how big your hospital should be really starts with joint strategic needs assessments. It starts with understanding communities. It starts with understanding what are the problems that we're here to try and solve. And then, as Rob has alluded to, thinking about that as a system. There's an important little bit of detail that is just worth flagging and making sure that everyone in this room leaves an expert on, and that is we have utilised the GLA numbers and predictions around when you think about the modelling for future size. So you'll see the stuff in the paper around how do we expect, you don't want to design and build a hospital for 2023 numbers, and by the time it's built and 10 years old, that you've got that completely wrong. And this country doesn't have a brilliant tradition on that. I can't think of an example where a hospital's been built too big and is sat languishing across the country. So we use GLA figures, and that's helpful because that's the same figures that you use in your planning within local authorities. The national team and the National Hospital Programme have used what's called ONS, Office for National Statistics, and so there's been some disputes. So across North West London, and actually largely London, we have used those GLA figures, and we'll continue to do that. But your support in that argument, I think, is an important one. Those of you who are good students of reports will have maybe seen trailed yesterday the National Audit Office report around new hospitals. And I think one of the points that the new hospital programme was particularly criticised for was perhaps over-optimistic issues around capacity. So our hospitals, whether it's Hillingdon here or the hospitals that we run at Imperial or Chelsea and Westminster or London North West, are, as you know, at very, very full capacity. And as Rob's alluded to, particularly in times of stress around winter, that gets right up into the 100% or even above. So there's an important piece in and around that. And I think the final thing, and I'm really happy to take questions on, is around what we think are some of the implications of the very latest announcement around the new hospital. So as Rob's alluded to, Hillingdon in getting a helpful green light to continue on the progress that's being made. Some different...
Which is, of course, huge news sitting here in Hillingdon. Exactly.
Well, and it's really important news for all of us, and I think we're maybe in the sort of bad old days of hospitals being in competition with each other, but I very much share your joy in and around that. And for those of us who are serious about thinking about how we look after the population in North West London, it's very, very good news. There's a lot of more work to be done around St Mary's. There's a specific set of arguments and certainly potential opportunities. And Angela and I were talking local to Paddington and North Westminster. And our hope is that with Charing Cross and Hammersmith, which for slightly odd reasons are lumped together as one scheme on the new hospital programme, that there will be some further opportunities. But the issue for those hospitals is that the funding has been pushed back to beyond 2030. So the offer is there of funding, but it's pushed back beyond 2030. And so there's a lot of work ongoing at the moment to try and understand what does that really mean. What can we do in the meantime? What are the opportunities to try and accelerate that? So I think the paper gives a good intro. I'm really happy to take any questions, as I'm sure Rob will as well.
So you finished on an interesting note, and before you finish, let me just invite you to expand a little bit more on the last point that you made. So what does it really mean?
So taking an imperial perspective, we for a long time have so the rebuilding of St Mary's, that is a major trauma centre. The estate at St Mary's is in a very, very difficult situation, and we have currently a ward closed because of estate issues. We have ongoing difficult mitigations around it. So we're concerned that pushing the timescales further out makes it harder and harder to run one of the busiest hospitals in London, with one of London's 4 major trauma centres, indeed the busiest major trauma centre. And so,
as Rob was just alluding to, that he's keen for there to be best possible setting for best possible outcome, and when you have what you're just describing,
exactly, and we have been really trying to make that point out with our communities, out to the national public, but also to the politicians, to the new hospital programme. The opportunity we have in St Mary's is perhaps a slightly different one to the way the new hospital programme is thinking about perhaps an opportunity at Hillingdon or in other parts of the country. And we think that a mixed funding model, where there is some funding from government, there is some funding from land sales. We also have a really interesting opportunity because of all the research we do. We probably do more research at Imperial College Healthcare than any other trust in the country, and so the partnership with some of the life sciences organisations that are already there in North Paddington and Imperial College London, our partner university, puts us in a strong position, but it requires a different set of thinking. And to date, the new hospital programme has been quite linear in its thinking, and has said that funding will only be publicly funded. And I think we probably need a mixed approach. So that is something we're exploring, and to be fair, exploring with government and with the new hospital programme about how that might be. Very quickly, Charing Cross and Hammersmith are likely to be a phased rebuild. So those of you who know those sites well will notice there are some buildings that are actually in good nick, and where the sort of space and quality of infrastructure that you would want. There are others that are really poor, and so they're the most likely way, and that makes funding a little bit easier. You're still talking big chunks of money, but the St Mary's conundrum is it would need to be a full rebuild, and in a relatively central London space, that's a lot of money.
Thank you very much for that. Let me bring Nick in, please. Nick.
Thank you very much for that update. We've obviously, on a sort of local level, done a lot of work and conversations within the hospital and other local health partners about the rebuild. And one of the really interesting things is the hospital's being designed for a way of working where more stuff can be delivered in the community as well. So it's not just about building a hospital with brick walls and all this sort of stuff, even though that's very, very important. And I noticed on page 9 of your report, page 17 of the whole pack, you talk about the need to undertake a holistic review to ensure we're making best use of facility staff, supporting better systems, all this sort of stuff. Now, the whole hospital programme, even though we're in a good place here in Hillingdon, and obviously it's good for the whole of North West London, we're still talking about 2030 for the new hospital. But there are lots of obviously changing health needs within that. Can you talk to me a bit more about how we can harness the whole of the health system in order to help hospitals work as best as possible?
Yeah, and I'm sure, I suspect Rob will want to come in at an ICB level, but let me just come in. Thanks very much. It's a great question. One of the mistakes you can make about building a new hospital is really what you've alluded to. You focus on this exciting thing that's going to happen, and rightly people are excited, and staff who, Hillingdon friends and colleagues who've had to work in dreadful, dreadful conditions, and patients who have families who've watched their loved ones be looked after, absolutely should be excited about the prospects. But even here, we're talking at Imperial 8 to 10 years, and here the timescales, as you say, are measured in a number of years. We absolutely have to change our models of care on the way to doing that. What you can't do is move into a shiny new hospital with 1970s healthcare practices. So I think there's a lot of good work. In some ways, COVID really helped to accelerate a lot of that. So you will be getting used in this committee to acronyms like SDEC, Same Day Emergency Care. Those of us on the children's side tease our adult colleagues for being a little slow off the mark. We've sort of been doing that for a good old while. We've had an advantage. We have parents and carers. But thinking about care that traditionally would have taken 3 days in a hospital, where people are coming in and having antibiotics? How do we have an assessment, potentially some scans and things that are done in a sort of one-stop shop way, then try and support people at home with remote monitoring, with people going out and visiting, crowding in various services that may well come through primary care on the NHS side, from local authority, from voluntary sector. So I think there's some really good work and starting to happen at scale, which is exciting on that front. And I think the paper alludes to that. The demands, we know multimorbidity is going to be more and more of an issue. It's slightly flattened, but thankfully people are living longer. But the risk around that is they're living with more complex issues. And so there's no two ways about it. Life in a hospital, in terms of the patients we see, I've just been working on the children's wards this weekend at St Mary's. It's more complicated than it was in summer 15 years ago. On average, the average patient's got more things going on. In a way, that's right for hospital, but we've got to keep getting these models of care. So I think the focus on that is absolutely critical, but we've got to do that together. And I think the thing, again, that's happened post-COVID, and certainly when I think across the boroughs to some of the best examples, it's where it is communities, local authority, voluntary sector, primary care, NHS services, mental health, community services, us lot in hospital, reaching out in a helpful way. And that's the key. And in a way, Rob's job, in my eyes, as the Chief Executive of an integrated care system, that's the prize we've got to do. And one final bit is we've got this wonderful asset here, which my organisation is particularly strong on, but is around research and innovation. So how to utilise technology, how are we thinking about offering up research trials to people who've never got involved in them. That sort of space becomes a key bit as well. But Rob, I'm sure will want to just come in on that.
Thank you, Bob. Rob?
Just very briefly, because Bob's captured it really well, I mean, the technical terminology is vertical and horizontal integration, and the Hillingdon Health and Care Partnership is a great example. Actually, I would go so far as to say, certainly through an external lens from Hillingdon, leading the way in some of that health and care partnership joint working across a place-based partnership to bring together the best of local joint working with the hospital and the community, the mental health, the primary care through the place-based partnership and the working partnership with the local authority, but also an acknowledgement that that scale in and of itself within the population history has shown that there also needs to be working across, and the Acute provider collaborative, to use the example. The outer ring hospitals work best if they've got that partnership working in partnership with their big acute partners and with their local partners, and doing both of those things and not one to the detriment of the other, both of which focused on need for local population, improvement in health outcome, reducing inequalities. So that is the integrated care system model. It is different from clinical commissioning groups just buying services from individual hospitals. It is attempting, as we will see on a couple of items today on ophthalmology and MSK, to buy pathways, to standardise, to deliver good outcomes, use data to drive that, and that does require some standardisation to get the best deal for local residents. Thank you.
Thank you for that. Marina, please. Good morning, Marina.
Thank you, Chair. Good morning, everyone. The data in the report shows that there's over 3,000 open beds in North West London. What is the proportion of those to the total number of beds? And also on recent NHS data from March on bed occupancy rates suggests it's as high as 100% for Chelsea and Westminster Trust, meaning there's no vacant acute beds. What additional targeted work needs to be done to bring this down to the target of 92%?
Rob?
Do you want me to say? So is the question, what's the proportion? 3,200 of our 3,150 of our total beds. Those are our total general and acute defined beds. We will have, and I've got numbers in front of me, several hundred. I could get easily community mental health beds, which are the other beds. Sorry if I'm misunderstanding the question.
I think, Rob, it was about occupancy. Is that right? So almost, if you look across the 3,000, what's our occupancy rate? And Councillor Sharma was talking about Chelsea and Westminster. But do you want to start, and I can always follow up?
Yeah. So apologies. I thought there was a question about what the total bed base was, excluding acute bed base. But we can provide that number. But if the question is about the total occupancy, then clearly and self-evidently, we have a standard to try and get 92% and indeed there is variation within that. You wouldn't want, in the acute, for example, critical care bed occupancy, etc. There is variation in what is ideal within that, but it is too high. But the strategy to do something about that is not to build more beds. It's to make sure that with all the things we've talked about up till now, in terms of the utilisation of those beds for getting patients into different care settings, more appropriate care settings, have a significant proportion of patients not meeting the criteria to reside. So our intention is to get to a sustainable position which reduces it, so it hits the 92% and reduces over peak periods of winter by having additional capacity to meet the demand during those periods, but not to have permanent increases in the bed base to do that, because we think there are more appropriate care settings for patients than those currently residing in that 92% and above, sometimes going up to over 100% occupancy level.
But Bob and Rob, but that isn't compounding the health inequalities, which Rob, you referenced in your opening remarks.
So of course it will potentially be compounding the health inequalities if we've got beds full and not able to be accessed, but again, the answer to what we're trying to do is to, and we've got really good examples, for example, a pilot on the ambulance waiting times. We've got some of the best handover times in the capital of ambulances getting back out on the road, making sure we're meeting need on a daily basis in respect to that. So the flow and the use of that capacity, of course, impacts inequalities of access to health and care services, but that's exactly why building more beds won't be the answer. It's building the new models of care to be responsive to local communities that is the answer.
Thank you for that. Did you want to come back? Thank you. Marina?
So with that in mind, what can be done to improve the coordination with care services to reduce the number of delayed discharges?
Thank you. Rob?
Okay, another big question. I would point to how lucky we are to be in Hillingdon today, which leads the way on some of the work around integrated discharge hubs that we have locally. I think the answer lies in partnership working between our colleagues, between local authorities, social care, primary care, and that joint working is important. There are some good examples of bridging services in Hillingdon, how we bridge, people talk about discharge to assess models. We need to have models that are the best for patients in terms of getting to the right setting. So the answer to that problem lies, again, not in building more acute beds and filling up with patients who are better treated elsewhere. The answer lies in is continuing the journey of local work, understanding that I'll put it in technical terms, we need to understand the detail behind, and we do now borough by borough, site by site, who's in and for what reason they are being delayed across hospital-based delays, community rehabilitation delays, whether it's equipment re-enablement delays, whether it is access to care homes, whether it is access to appropriate support packages in the home. And we are getting more and more forensic in understanding those different component parts of why those delays occur that are not in the interests of our residents and patients. And of course,
hopefully working better with the local government.
And then tackling those issues. Sorry.
And hopefully working even more closely with the local authorities.
Correct.
Thank you, Bob. Very, very quick point.
Yeah, just quickly, just to really look, this is about relationships, and Rob's alluded to. I think the integrated care system has an enabling role here, but as somebody who works, my clinical work out of some areas, but hospitals in Hammersmith and Fulham, lots of impact on lots of our boroughs. It's all about relationships, as you say, with local communities. And one final point is, we're not great at this in the NHS, and I think we could improve at it everywhere, is we get talking about words like flow and discharge and referral. These are people who live within our communities. You use the language of residents, which is a good word, or citizens, and we just sometimes can forget that when we're looking at numbers and things. This is human beings. This is really, for me, where the focus of it needs to return.
Thank you very much for that very powerful point. Thank you, Bob. I would just ask colleagues if we can be a little bit more briefer, because I'm just looking at the clock, which is bang opposite my eyes, and I am keen to get as many questions as possible. Let me now bring Lucy, please. Lucy, good morning to you.
Good morning. I think just going off on what you were just talking about, I'll start with this question, and that's just where you speak about how planned treatments that originally required an overnight stay can now be performed as day cases, and just to understand how that's being decided, and in the same way we're talking about humans and not churning people out just to ensure that beds are free, which of course is what we want, how that risk assessment is being done. And then my two further questions were, what are the implications for patients in the inner London boroughs of not having the St Mary's site developed by 2030, and how quickly do you think it will take to secure additional funding and alternative design approaches?
Thank you. Three brilliant questions. Thanks so much. I'm going to very quickly go, and recognising time, going to go to patient story. So from this weekend, so I was there with on Great Western Ward at St Mary's with a 7-year-old girl who came in with infection, and she came in at 5 o'clock in the morning on Sunday morning. I saw her on Sunday morning on our ward round, and she'd had some IV antibiotics into her vein and was already getting better for a presumed infection, probably had come from her throat, and we'd looking at a whole number of other things. Lovely young couple who were her mum and dad, English not their first language. We managed to find a healthcare assistant who spoke their language to have a really good conversation. Lots of anxiety, but a sense of relief that she was heading in the right direction. She, from a medical perspective, almost certainly could have... I saw her again about 6 o'clock that evening. She'd made really good progress. From a medical perspective, could have gone home and had one of our nurses come and visit her in the home on the Monday, so yesterday, to do the next dose of antibiotics. And we had this discussion in the morning, and I started to just sort of talk about that pathway ahead, and you could see they were quite anxious. I said, look, relax, let's revisit it in the evening. It's going to be your choice about whether you stay overnight or whether you end up going home. But let's make that decision. So came back at 6 in the evening, had a lovely discussion with them. Medically, I was happy for them to go home in a way they were going to get the same treatment. But I could just sense, I've done the job long enough, that they were just still a bit anxious. I'm not having to take them home, they are. And so their decision was to stay. But actually then they got going really early the next morning. It has to be those sorts of conversations. So live, real sort of thing. What you need there is really senior, well-trained people who understand people and understand the medicine, and actually it's not very difficult. But if you keep humans at heart. Just on the St Mary's bit on things, well, we are worried that if St Mary's does not get rebuilt, it will cause us as a system, at some point, the risk of catastrophic failure goes up and up and up. And we've had that at the level of having overnight to shut 24-bedded ward, and that when your capacity is already running in the high 90s, that has implications. And so it is a whole system problem that St Mary's is so critical around it. And so we are absolutely working day and night and sort of trying every trick in the book to really make sure that we get things forward. We absolutely, in our opinion, have to bring that funding opportunity forward from 2030. There may be some interesting opportunities. So what the new hospital programme is saying to us is they expect slippage on other schemes. So part of the onus is on us to be very ready and making sure that our plans are in really a good state. So our relationships in with colleagues in Westminster City Council and thinking about planning and things like that and getting that work done in advance is key. There is definitely an opportunity around life sciences and the commercial side of things, and this idea that actually some of the land may well be able to be released for building science and research opportunities that bring local jobs in and have wider benefits, as well as getting the finances right to get the hospital rebuilt. So we are very, very determined, and have got lots of energy and expertise working on that, and crucially back to partnership, working in partnership. So we're absolutely, if we sat back and resigned and said, oh well, we'll just have to wait till 2030, I think we'd be in trouble, and we're categorically not doing that.
Thank you, and very reassuring on the bit about how your risk analysis is.
Thank you.
Thank you very much. Angela, did you want to come?
No, it's enough.
Thank you very much. Thank you. Let me bring Chetna in, then I'll bring Natalia in. Chetna, please.
Thank you. On page 5, it mentions about the £26 million coming from NHS England. Would like to know in Harrow, also for this committee, how this will be used for wards in North West London, and in particularly Northwick Park Hospital, which affects Brent and Harrow residents. Thank you.
Thank you.
I think that's probably one for Rob to kick off on.
Yeah, so I'm just trying to find the reference. Apologies. Page 5.
Page 5 or page 13, whichever number you're looking at.
Yeah. Which paragraph, sorry? The 26 million...
Second paragraph.
That's right. It's about, I think, winter pressure, Rob. The only other thing I'd just add on it, which is a really a sort of daily operational thing, is we're really working together like we've never worked before. So the reason you haven't got Tim Orchard here is the Acute provider board are meeting. So the situation here, if there's a Brent resident or a Harrow resident who's severely unwell, and their natural place would be to go across to Northwick Park, if we know that because there's so much going on there, the beds are very, very full, and we've got a bed in at St Mary's. That work is now much, much better done up front, and the conversations and work with London Ambulance to divert an ambulance to the right place. So we're really committed to making sure patients have care as close to home as possible. But in the case of where somebody's severely unwell, the weighing of that up versus getting on with the emergency treatment in the most appropriate place, and the progress on that over the last year or two, and I think it's been a really good legacy of COVID about working together, has really changed. So how we're utilising our bed stock across the hospitals, whether it's children's or adults or intensive care, has really, really changed. And I think as we work together more and more, that will continue to get better.
Thank you. Can this committee or maybe Harrow get ongoing updates on this? That would be appreciated, please. Yes, thank you.
Thank you, Chair. I just wanted to say that from Hammersmith and Fulham, we're extremely concerned about what's happening with the new hospitals program. We've had our Health and Wellbeing Board, and we have received evidence and information of the extent of the difficulties that the hospitals are facing. So we've heard how St Mary's Hospital has had to close wards because of the circumstances in which they find themselves. We've heard of sewage leaks. We've heard of sewage blockage. And it's not only St Mary's, it's also Charing Cross Hospital. I know the situation is not as bad, but we were promised a floor-by-floor improvement, which is not happening. There's no specific date of when this will happen, post-2030. We also are concerned about Hammersmith Hospital, and it's very interesting what you're saying in terms of the systemic approach. So my concern is what will happen in the event that there's a reduction in building capacity. Will this impact the provision of services for all of us? Also, is there a contingency plan if St Mary's cannot sell off land? I appreciate that maybe it's early days, and you've mentioned how you are exploring different options, such as new opportunities or with planning department. But are there contingency plans in the event that the selling of land is not possible for St Mary's? How will this impact all of us, bearing in mind that the report also talks about projections? You've alluded to the Office of National Statistics, a population increase of 15 to 20%. I think it mentions from 2090 to 2035, and also a capacity modelling shows a need for an increase in beds for St Mary's from around 600 to 840. Then we also have this big question about the new hospitals program. So
Okay, lots in there. Listen, the happy news is I'm coming to see you tomorrow evening to spend some time in Hammersmith and Fulham with you all. So you've got to put up with me 2 days running. So I think a few comments to make. I'm going to start with relationships. We talked about that in the context of delivering care for individual patients, but I think in tackling these big population-based issues where we're talking about landing clear arguments with national government, we're talking about hundreds of millions of pounds or into the billions, we're talking about long-term investment, we're talking about local economy and how that plays in with national politics and economy. The critical thing is that we work really well together, and I certainly in the time that I've been on the executive team at Imperial over the last 4.5 years, in my opinion, I've noticed stepwise closeness of working in partnership. Long may that continue, and my motivation to be here today is part of that story. So I think that is really critical, and we really appreciate and greatly value the support and insights that you bring us from your residents, from local authority. We have to keep working together really smartly on that front. The specifics around St Mary's, we'll go into those in lots of detail. I've sent you some gruesome photos. I've found myself a recent film star on ITV News last week where they've been doing some investigation. So we are trying to land a message that the situation is really difficult. It's a very nuanced message because our hospital still delivers really high quality care. It is a safe place for residents, your residents, our communities to come to. So we don't want to scare people from coming to hospital when they need to come to hospital. But we are concerned, as you are, that this cannot keep going on and on and on. Specifically to St Mary's, I am confident actually that we will be able to get a mixed picture, provided the approach from the new hospital programme up until this point has been this has to be fully publicly funded. And so that's been the public approach to it. I think that is starting to change, and we have had some conversations with the very top of the new hospital programme, with Lord Markham, who is responsible for that, to say, look, that the two things can't square. You can't stick to that angle and also say this is going to go beyond 2030 for the reasons we're explaining. So I think there's an openness that we're starting to see. The relationship in an openness to consider other ways of,
and willingness.
Indeed. And I think there's a real understanding at the top of government of how critical the issue is at St Mary's. I really don't. It's difficult. The economy is not full of cash, but I think there is an understanding. And then our relationship with Westminster City Council and colleagues there in terms of working through to get the very best possible plan together that benefits local residents but also the wider sector, and actually at a national level because of all of the research and opportunities. You think about London, the major trauma centre is key. So I am confident we are continuing to put thoughtful work in around contingency, but I think we are still putting most of our energy into these plans. Where do you put your energy? But we've got some confidence, and we have to bring that forward. So I hope if you get left with one message, there's a real determination. We are not sitting around, oh, well, never mind, this is tough, it's going to drift. There's absolute determination, and your help in that is key. Specifically on Charing Cross, and we can talk more tomorrow, I do think there are still opportunities again. The big opportunity we have with the new hospital programme is continuing to further our plans. They have talked quite openly, and actually the National Audit Report's worth a read because it does touch on some of this, that there will be slippage with other schemes. And if we have really good local plans up and running together the work that we've got in Imperial to submit our business plans for Hammersmith and Charing Cross in the autumn is going to be really key. So again, great partnership working in on that space to make sure we've got good plans so that we can realise any opportunities that come pre-2030 is going to be key.
Thank you very much. Bob, when I leave this meeting, I'll be travelling along Met Line. And if I were to meet another fellow resident who asks me to explain to them about providing some reassurance that there's going to be enough bed capacity this summer, this winter, for the next 3 years, what would my brief message to this resident be?
Yeah, so I would focus on the working together. I hope you've seen from Rob and myself, who sort of on paper work for different organisations, but and didn't spend at 6 o'clock this morning having briefing calls around it. The truth is we are working closer and closer together, and critically with our partners in local authority, within our local communities, with amazing people in the voluntary sector around it. I think that partnership working is going to be the key to getting us through the next few years. Yes, initiatives like the beds up at Northwick Park and getting pockets of money are helpful. We have to get the funding through to make sure that we get Hillingdon continuing over the line. It's feeling good and positive. We've got to get those pieces through. So that's the long-term work with short-term issues. But for the short term, it is about working together.
Thank you very much for those very helpful replies, Rob and Bob. Rhymes, doesn't it?
It does.
Thank you very much. So, colleagues, before I progress the meeting to the next paper, are there any recommendations that we feel that we ought to be making for our colleagues? Any recommendations? Yes, Nick.
A woolly recommendation for us to work better on, but this talk about vertical, horizontal working, getting it all right, seems really, really critical to me. And essentially, I want really more details about how that's going to be done. I mean, in Hillingdon, I think we do it very well, and I can see what we've done, but on a northwest level. So I think that's something we, as a committee, should investigate more, because it sounds like it's such an important thing for making what Rob and Bob are talking about to work. So
thank you.
Something for the future.
Thank you very much. Any other recommendations, colleagues? And of course, not really a recommendation, but just perhaps an update. It'd be really good to hear, not immediately, but in fullness of time, the progress that you are making, which you just talked about quite a lot. So it'd be really interesting for us to know that there is tangible progress being made. Thank you very much, colleagues. So now I move us to the next paper, which is the eye care, which is all changing. Rob, you got your finger, you got your hand up.
Yeah, I'm going to front this one up again, Chair.
Thank you very much, Rob. Sorry, before we start, Rob, Bob, I don't know whether you're staying for the duration of this meeting or whether you have to go.
I'm going to stay for a little bit and listen, but then I'm afraid I'm going to have to go a little bit early if that's okay.
Great, thank you very much.
Thank you.
Yes, Rob, do continue with the key headlines, please.
Thank you, and I will keep it brief because I'll take the papers read, but the key drivers here are that we have varied provision of community ophthalmology services, that we believe that the local optometrist is the best port of call locally for people to work with and to vary what currently sits as a confusing landscape between general practice and optometrists locally, to have that single point and to standardise the model of care across northwest London to improve that offering for residents and communities. We also have the driver that there were the OPROS contracts in Ealing and Hounslow were coming to an end over the course of the summer. And therefore we've tried to align those events with a new procurement process that we have not yet launched, but will do so imminently. But we're here to seek the advice of the Joint Health Overview and Scrutiny Committee on how we best monitor and engage on that going forward. There is an intention and events already been scheduled and booked in to involve and engage the communities through the procurement process, which runs through the remainder of the year. And we would wish to take your advice and comments on the proposed approach. I do want to bring out, which is obviously the most sensitive area, rather than you'll be coming through a different route, that pediatric ophthalmology is an area that will be moving in the immediate term because of the ending of the OPROS contract into the acute hospital. So again, as another example that Bob's alluded to of working across community and acute settings, our acute providers have stepped up, and there is choice being offered to children currently in that system, which hospital is best for them to attend for what previous services provided by OPROS for pediatric ophthalmology, with an intention to have a more medium-term approach to sorting that out in terms of options available. But specifically, for example, in the borough of Hounslow, Moorfield, Ashford and St Peters for Hounslow, Chelsea and Westminster is also an option for patients in central Middlesex with small numbers of patients transferred to Imperial. So that is I acknowledge up front the gap that this has caused that we're managing at the moment. But whilst we go through the procurement and create a more sustainable medium-term picture for paediatric ophthalmology services, we do still wish to push ahead with the standardisation and best models of care across all 8 boroughs.
Thank you for that, Rob. We've got Sarah Bellman with us this morning. Sarah, I know your team does an amazing work with communication and engagement with our residents. So, feel free to just chip in. I know I'm exclusively concentrating on Bob and Rob, but by all means, do come in at the appropriate time. And before you leave us, Bob, for your the rest of the day, your other commitments, it'd be really good to understand a little bit from you, if I may, because I know Western Eye Hospital has recently opened, and I wonder, what we've just heard from Rob and the desire to have the better outcomes. How does that particular service going to help in the short term? But I guess much more on a longer term. How does the picture look, please?
So I guess just the reopening of Western Eye, I think, has been really important for us. And again, I think there's a sort of short, medium term and a long term approach to this. In the short, medium term, that has given the staff a real boost, getting back to the environment that they know well and the space that they are used to. We have really good experience of the Western Eye in the lens of paediatrics, and this is leaning on me as a paediatrician about the help and support that they give across our sector in terms of looking after children and young people who have eye disease or concern about their eyes. So they're very responsive to short-term issues. You imagine anyone in the room whose child has a sudden worry about the eye. It's the sort of thing you really want to get a move on. And so the emergency and urgent service at the Western Eye is very responsive to that. But the other important angle, you might be a paediatrician working out here at Hillingdon, and there's a child with a particular condition that is associated with also having eye symptoms or eye concerns. And that is the sort of specialist expertise that those of us who are just paediatricians don't have. And so we need to lean on our specialist colleagues. So we talk earlier, and I think Nick's point about this vertical integration, this is a really good example of that. You can't have paediatric ophthalmologists at every hospital and in every community centre. The trick is, how do you escalate up and down this, think of it like a lift, this care, so that a family who are out here, say in Hillingdon, they meet their paediatrician, they identify that the eye is an area of concern. How does that link across with real speed and thoughtfulness into that specialist expertise, and then really crucially back? So maybe the recommendation of the implementation of treatment actually can all be done locally here because the advice is coming on the phone. So it's that sort of working that we're looking to try and do more and more and more of.
Brilliant. Thank you very much for that. Let me bring Angela, please. Angela?
My main concern is how you're going to ensure...
Your microphone, please, Angela. Thank you.
How are you going to ensure the quality of care at the potential patient's first point of contact? Because you've got a whole range of different private, etc., optometrists, and they won't all have the very special equipment. And I'm thinking particularly of things like glaucoma, the whole pressure thing. So how are you going to ensure the quality of care across the board before they're even referred on to?
Absolutely, and I think, it'd be good to hear Rob and Bob, if you want to come in here, and I'm very happy to hear from Sarah from her resident engagement input. So how are we going to ensure that, the experience that we have in one particular high street is going to be pretty much similar elsewhere in our geography, or the experience that we have at Western Eye Hospital, for instance, is going to be same as the experience at Moorfields Centre at Northby Park Hospital.
Okay, so I think this is a strong argument for why standardisation is an important part of driving up standards and quality of care, because by defining a standard pathway, by defining the expectations on optometrists and being able to monitor both experienced data feedback involving patients using services and quantitative data feedback, by having clear, measurable pathway milestones, we're able to look at variation as a system and pick up where services are falling short in terms of quality. So that by standardising the contract's approach to what the pathway expectations are, the expectations of the service in the optometrist, the criteria by which, where there are, say, variation in what is able to be done in a particular optometrist, what the protocols are for their onward referral to other parts of the system, where that can be done, for example, you mentioned glaucoma, and making sure that there's an appropriate threshold where people are referred into hospital at the appropriate point, and that there isn't both an expectation and a way of monitoring how those services are performing on those referrals and the monitoring it back. So that compares to a current situation in which we don't have that standardised approach, and we have in some parts of the northwest London, a lack of clarity between general practice and the optometrist as to who's doing what at what point, and therefore a lack of clarity of how we monitor outcomes and measure that, and therefore an inability at the moment to really drive forward that quality, which I would hope that this will allow us to do more effectively.
Thank you. Natalia, please.
Thank you, Chair. I just have a question in relation to the ophthalmology engagement analysis for the London overview on scrutiny committee chairs, and I note that there's a question 2 on ophthalmology survey analysis, where people are asked which borough in northwest London do you live in. So there are various options there given to the people that were being interviewed. You've got Hounslow, Ealing, Hillingdon, Harrow, Brent, and then you've got other. So my concern is by just having other, is somehow Hammersmith and Fulham underrepresented, and the feedback that the residents in Hammersmith may have, how is it captured? Thank you.
Yeah, a fair question. I think actually the way it's set out in the analysis is a bit misleading.
Oh, sorry about that. Sorry.
So we didn't ask the question as other. We've not captured some boroughs as other. We don't want to know. This is about how people answered the question. So we always list all 8 boroughs and then other. Some people, for various reasons, never like to say where they're from. With the survey, we didn't get people responding from every single borough, but that's why we didn't just do the survey. Just doing the survey never works well anyway. I know if I came here and we'd just done an online survey, I'd get a really hard time, because that's really problematic with sort of access to sort of obviously the internet and inequalities. We did events in every borough, so we did face-to-face events in every borough. So the broader analysis beyond just what we heard in the survey absolutely looks specifically at people from Hammersmith, people from Westminster, so those other boroughs. That's literally just in the survey itself, so the 101 responses we got physically from the online survey, nobody identified themselves as being from Hammersmith and Fulham, but that's why we've done the additional work, and that engagement work is ongoing. So.
Thank you. So just for reassurance, voices of Hammersmith and Fulham residents are also being taken into account, that are incorporated by the other means that you have described.
Absolutely. Absolutely. And even when it's sort of, we've got the difference between sort of like an engagement or a full consultation, we will always take the approach of not just which boroughs aren't covered, what demographics aren't covered, what groups are we being representative of the service user base. And what our team will always do is go, okay, so we've done this, we've done our first bit of engagement, has it covered everyone that we want to hear from? Would we be able to do a really good equalities analysis of this? If not, no, that's when we go out and we go, right, where are our gaps? Where do we need to go more? We've worked with a lot of different local groups, patient support groups, community groups, so absolutely we've done that. And what I can do is I can share the more detailed analysis if that's helpful.
Sorry, of all the engagement sessions, I think it was, 14? You have received 101 responses. So you talked about how representative that is, and how can you be reassured that what you've had feedback thus far is going to be sufficient enough to be able to follow that forward in a meaningful way?
Okay, so I think if I start from the challenge that we always have with engagement, which is 2.5 million people, to be fully representative of everything and everyone and everyone's different experience. In some respects, there is never enough. There's always more we can do, and we always want to be more. And that's where working with we work a lot more closely with the local authorities, with community groups. We will always try and push out an awful lot more.
So can I just ask Sarah, in that case, do you have any other such sessions in pipeline? Do you hope to be doing a lot more work in coming weeks or months to give us that fuller picture?
Yes, so this is very similar to what we'll sort of come on to talk about with sort of MSK as well, is when we're supporting a procurement, there are different phases of the engagement. We don't do, right, we've asked some questions, stop, we've heard from everyone, let's move on. It's about how can we continuously respond to the service design that's happening. So we have done this initial piece of work. We have done the online sessions. We've done work with community groups. We've done the sessions on the ground. That has fed into the procurement, and that has helped to feed into that work. What we are now doing is saying, okay, where do you need us to go a little bit more in depth? Where do we then need to go, okay, what have we learned? Let's make sure that we're getting the implementation right. So this is absolutely not the end of engagement. This is, here's where we've got to so far, so we can continue that conversation.
You. Natalia, I'm sorry, I was still just on there. Thank you. Anything else? Thank you. Let me come to Marina, please. Marina, thank you.
Thank you, Chair. I was just wanting to know, about the potential of using AI in helping in the interpretation of scans.
I don't know whether, Rob, you want to pick that up for me, please?
Well, it's a huge subject area, so absolutely. And what I would say is, if we are going to innovate and have new models of care, the standardisation that we're describing here is a sort of prerequisite, provides the ground in which we can add that innovation on Bolton letters. But we've got a whole research and innovation programme and AI, but also there's lots of complexities around governance, the use of patient data, how those algorithms are generated, who owns them, whether that's passed out to third parties, etc. So that is a minefield, but in order to grab that opportunity, that's why we need to standardise some of this stuff, so we've got partners with whom we can implement innovative new models of care, learning from artificial intelligence models and algorithms that we can apply, and that is one of the benefits of what we can do by doing this on a cross-population basis rather than individually in every integrated neighbourhood team or local area.
Thank you very much for that, Marina and Rob. Let me come to Chetna, please. Thank you, Chetna.
Thank you. So whilst a lot of work is being done by the optometrists in the community, in particular to do with standardisation, what is available, in other parts of the country or London about this sort of service? There must be other studies and research. We can use best practices, as you've mentioned, best models of care that we can use to, support this.
Thank you. Good question. Yeah. So, Rob, what are the lessons that we have picked up from elsewhere, please?
So, absolutely, and as you...
Can you... sorry, we missed that. Can you start again?
Can you hear me?
Yeah. If you could restart, please. Thank you.
Yeah, absolutely. Best practice is built into the learning for the model that we're describing here. I've referenced, I think there is some reference to getting it right first time, a national programme which looks across the country at what outcomes and variation in service models are, and this has very much been informed by that national work. So whilst of course it is important to involve locally, the origins of this model are based on international and national review of best practice, and I particularly reference the getting it right first time, the relevant royal colleges and professions in optometry and ophthalmology as a basis upon which this model has been generated. So it isn't something we've made up in North West London. It's been informed by that process. So,
Rob, can I just ask, so getting it right first time, of course, that is what we want, and thank you for echoing that. But how do we monitor that, and how will you be monitoring that, please?
Yeah, so I won't repeat what I said earlier, but by having the standardised pathways and the expectations on what getting it right first time actually means in terms of measurable outcomes, we will then be measuring that as part of the contract management process that is set up here. It's easier when we've standardised it to do that, to see the variation that we have that is not explainable by other factors. And so the contract management processes that will be responsible through our acute programme of care that we have as an ICB will allow us to, through our performance monitoring up to public domain monitoring in the Integrated Care Board, to show where we have variation from the standards that we're expecting to set up within this contract will form part of our performance reporting and reporting in the public domain going forward.
Thank you very much for that, Rob. Chetna?
Thank you very much. We look forward to progress on this in the future.
Thank you, Chetna. Let me bring Lucy in, please. Lucy, thank you.
Thank you, Chair. I was going to start with, what is the North West London performance against the national benchmark for referrals or procedures in sight-threatening conditions? And health inequalities are not mentioned in the paper, but addressing inequalities is a key purpose of the new integrated care system. Would you be able to supply the committee with some more information on this, and how will the new NWL address health inequalities in eye conditions?
Thank you.
The very quick answer is I'm not data press, but can provide the baseline data that is informed. That very happy for that to go to the committee in terms of current performance, because it is not where it needs to be in terms of the standards we'd expect, and that includes where there is not the service performance that we would all expect. That exacerbates the inequalities, so that by standardising this and by implementing this model, it will be the route through which we are addressing the inequalities and the need to have local services that are reaching out to communities as part of that. So yes, providing baseline data, and I think this model is part of the answer to addressing inequalities currently, that data is telling us is out there.
Sorry, just to follow up on that, you said it doesn't sound like we are at a great benchmark position. How bad is it?
It depends how you measure how bad, because it's the variation that's particularly across the sector, and we I wouldn't want to quote without giving you the proper data exactly how off best practice we are at this point in time. I'd have to give that in a separate quantified assessment.
Yeah, I think that would be very important for us to see. Yeah. Thank you.
And that has the breakdown from for both pediatric as well as adults, does it, Rob?
Yes. Yes.
Okay. And is there do we have any information as to how the pediatric service is doing compared to the adult service, or are they both equal in the same light?
I think it would be far too simplistic a generalisation to say that one is worse than the other or better than the other. I think we need to refer. So we have variation. We have variation in rates of blindness across North West London, which we want to improve, and are not there at the sort of national benchmarks of level of best practice that we want to achieve. And there is variation in both the paediatric and adult service, but it's a complex picture to summarise in one headline.
Sure. No, I understand.
Where that variation is both by. So, and we'll provide that data.
No, I understand, absolutely. And just a small supplementary, Rob. So we do have that benchmarking against the neighbouring ICBs, London and National, do we?
Yeah. So yes. Sorry, apologies. Yes, we will have the baseline rates have national standards that can be compared.
National, but also London. So like for like national, maybe, you know, if you're comparing to Yorkshire or something like that, that might be not true comparison.
I can commit to knowing our data. I can commit to knowing national data. I'm not necessarily, we may have it, and I will check, to have that national data broken down by each borough and relevant geography across the country. I know that we've got our own data, and I know that we've got national benchmarks and standards, and I'll commit, if we do have the access to the data of other parts of London, to provide that. I just don't know off the top of my head whether we have that to hand at this point in time.
No, that's very helpful. Thank you very much for that, very helpful clarity. Sarah, please.
I was just going to come back on one of the points around inequalities. So it's not maybe drawn out as much in here as we perhaps should have done, but when we were having some of the conversations on the ground, a couple of the things that we really started to hear was about the challenges of location. So where we don't have that standardisation, where not every single optometrist can currently refer, that's an immediate barrier for people who don't have their own transport or can't afford to use public transport as much. So we were hearing about that. The other thing that we really heard about was people saying, well, actually, eye services you've got to pay for, therefore I can't go. So that's immediately allowed us to go, okay, so big challenge is people don't know what NHS support is available out there around cost of living, around the people who can access certain NHS services free of charge. So it's a little bit of a tangent to the side of this, but actually one of the things that we've started off the back of the engagement already is what can we do with certain communities around just really promoting what support is available around, you know, not just optometry, but dentistry, prescriptions, wigs, all of those things that can really help people at the moment. So it's very much related to sort of inequalities, but there are certain things that we can start to support now to sort of help people get in the system and start to get the support they need while it's still doing this piece of work.
Thank you for that, Sarah. Thank you. Just if I can, sorry, did you want to just pause for a water? Thank you. So Sarah, I just wanted to very quickly finish by a quick point, if I may. So obviously there'll be contracts which are coming to end, and new contracts will be coming in. So there'll be, you know, perhaps an interim transitional period. You already talked about engagement and communication and the work that is going to be continuing. I just wanted to just finish by understanding a little bit more as to what is going to be happening in the coming days and weeks. And I guess I'll be asking the same question to Joe when we talk about MSK, because obviously, you know, it's good to be able to understand for our residents, you know, what is happening.
So my answers to sort of on probably both of these will be very similar. So at the moment, what we're doing is we're ophthalmology a little bit further ahead. So we've done the analysis of that, fed all of that in. We're waiting for the team to kind of like have that conversation with us and say, okay, what more can we go out and explore a little bit further? What our team are doing is having a look, and partly that cost of living bit that I was talking about, but we are starting to think about, once this is being implemented, what are the things that we need to talk to people about? So very much trying to make sure that all that communications work is driven by the engagement and what we are hearing through community engagement and how people want to know about services. It's all very well us sort of going out and saying, this is the new service, this is how to access it, but actually we often have to go about 10 steps back from that to talk about, you know, why eye health is important, you know, the fact that you can get support, where you can go for support, kind of signs and symptoms to look out for. So a lot of that sort of preparatory work is happening at the moment within the team. If there are particular groups that any councillors have got that they are aware of that you would like us to go to speak to, I'll share the work that we've done. If anyone feels that there's additional work that we need to do in any boroughs, do let us know, because we are out on the ground every day. We don't just tend to go out and talk about one topic when we're out and about. We talk about all the things that are relevant to people. So
thank you. And of course, Bob was, you know, explaining in some great detail. And of course, this also includes the partnership work with the local authorities to make that reachable to the residents on the ground.
Yeah, absolutely. I would say, and I'm not just saying it because I'm here, but actually without the support of your own comms teams, we couldn't reach as far out as we do. So that's so helpful nowadays.
Thank you very much to Rob and to Sarah, and of course to Bob's helpful contribution at the start of this paper. I'm going to bring this paper to close, but before I do so, are there any recommendations apart from the natural stuff that came out from various replies? Thank you very much, George. Very helpful, George and Nikki have very helpfully noted those points, and those will be communicated with our NHS colleagues offline. But unless there is any other recommendations or any other points that you would like me to take, then I'll make progress. Thank you very much. So then we come to the next paper, and I was just alluding to MSK. And Joe and Rob, I don't know whether you're both going to be doing a double act, but...
I'll just briefly start to say thank you, Joe, for being there, and repeat my apology for not being in the room. What you are about to witness is a vision of the future, which is where our borough-based teams lead the way across North West London in coordinating across North West London activities. So Joe's done a fantastic job in bringing this work together. So I'll hand over to you, Joe.
Thank you. And Joe, you're no stranger to scrutiny, but perhaps you're coming to the JHOSC for the first time.
Yeah.
So very welcome to you.
Yeah, I just want to say thank you for welcoming me here. I am the North West London Integrated Care Board Borough Director for Westminster, but as Rob says, I'm working across the 8 as well. I just want to say just a little bit on my end personally is that I started my NHS career in Hillingdon, and Sandra was the person that taught me all about adult social care. So I just
well, you can see Nick with a big glowing smile.
And Nikki has, I think we've yeah. And I was just going to say I've actually been lost in this building so many times now that I'm not sure how many hours of sort of wasted time. But yeah, so I'm very familiar with this building, but I'm not sure where Sandra sits now. So also I just want to send just apologies from Imran. He's actually studying for his exams for he's trying to become a specialist in sports medicine, which is around MSK. So just wanted to send him my apologies, but I'm happy to field any questions around that as well. Just wanted to start out that I'm actually one of the statistics, the 20% of people who experience MSK related issues as well. So getting into my older age now, or my next phase of life, I'm now also sort of going through my proactive care plan at the moment to reduce some of my issues there. So it's definitely an area that's near and dear to my heart now that I'm experiencing it myself. So as Rob and Bob had alluded to, this is part of an opportunity for us to really look at musculoskeletal services across North West London, because there is indeed a lot of variation across, as I've alluded into in my paper. And also, from what I understand from my London colleagues and national colleagues, that this is quite an ambitious piece of work that we're trying to do around MSK. Not ambitious because of what we're trying to do, but ambitious in terms of trying to bring this across 8 boroughs and really trying to look at the services across. So we're in year 1 of a 5-year improvement program around MSK, and phase 1 is all about us now really understanding what the best practice is around musculoskeletal services, and really understanding the variations between the delivery across our boroughs. And also, I think sort of post-COVID now as well, really looking at the inequalities agenda and really understanding that, because we do know that, as I mentioned in my paper, 13% of residents have chronic MSK issues through the sort of the JSNA work that we've done as part of our strategy, but it also does contribute to second highest absences from work as well. So there is a huge interlink between how we're working with communities, but how we're looking at employment and how we're supporting people in a wider sense. I think the other piece for us is that actually not only from the first part of engagement work, but it's an area we've been running, I think for 8 years now, sort of an MSK group with all of our practitioners, patients, and different groups as well. And I think this is not only that we're following best practice, but I think also on all of the feedback that we've had, the complaints and everything that we've had around MSK services that have fed into a lot of the work that we're doing. And I think one of the key things for me when I do speak to patients or residents as well around this is that our MSK services sometimes could be a little bit of a checklist as well, where we go through that process. And actually the biggest opportunity here for us is really kind of stepping back and looking at what really matters to people, and this is around the personalization agenda, because we all go through processes and we all live with MSK conditions in different ways, but this is about actually being able to understand what people's goals are. And that really, for me, is the biggest change I think that we're trying to introduce as part of this, is really understanding where people want to get to. So, for example, I take care of a dog, twice a week. I want to be able to walk that dog and run with the dog as well. That is one of the goals that I have, and I'm sorry I'm talking about myself because I guess I'm expert in terms of myself, but everyone has different goals around this, and that is something that we're not consistent across, and really understanding what's driving that, and that's one of the biggest features that we're trying to really address as part of the service moving forward. Also, one of the other areas is around addressing some of the integration integration with acute interventions as well, because we are not consistent in terms of how we're bringing in rheumatology, pain, and orthopedic input into the MSK services, and that needs to be sort of addressed as well, and that will be addressed as part of this work that we're doing across the 8 boroughs as well. And also, one of the things that we have found is that spend doesn't actually correlate to the prevalence and needs as well. So we've done a complete refresh in terms of our prevalence needs and making sure that the spend is aligned to that across the 8 boroughs. And also, we're starting to now look into working with our partners around how we can support around the employment piece as well, and just that sort of return to work piece. Just in terms of what I think people are telling us at the moment, so I've talked a little bit about patients, residents not feeling understood about their condition as well, but also the wait times are varied across the boroughs as well. Some boroughs are much better than others, and that's because some boroughs we have actually brought in that single triage self-referral offer in, which we want to harmonise across as well. And it's really interesting because with online appointments, we hear mixed messages around that, and some people do like the appointments, but some people don't. And this is about us making sure that we've got all of those different modalities in, because it really just depends on individuals what works for them, and we need to make sure that that offer is there for people, and it can be personalised and tailored to what they need. Also, I think for some of the services right now as well, sorry.
Carry on.
No, it's okay.
If you want to finish, thank you.
Yeah, I'm just going to finish in terms of, let me just go straight in terms of what I think are the key changes for us. So we've talked about that common offer. We've talked about a little bit about the single point of access. That for us is really key, that we're bringing together all of the clinicians, the practitioners into one function, which will be helpful for the residents as well. And then the other big change for us is around staff development in this area, because we don't have consistent development around MSK services across our partners, which this will allow us to improve on. I've talked about the modalities as well, and just being able to supplement some of that. And then the last thing for us is that part of this work for us now, as part of our engagement work, is to really now reach out to the communities and really understand why people are not accessing services.
Great.
Yeah.
Thank you very much indeed. Really grateful to you,
yeah.
And of course to Rob for his opening few words as well. Let me bring Ben in. Ben, your question, please.
Yeah. Thanks, Rob and Joe as well. Like you, Joe, I'm in the 20% of people with MSK issues, so I'm quite familiar with the services. By 2025, there's going to be approximately 9.1 million people in the UK that are living with long-term health conditions in general terms.
Yeah.
Of the people over 45 years old who report living with a long-term condition, 3 in 10 relate to MSK, and that number is growing. So I wonder, question to you and Rob, how confident are we that the proposed model that we're designing here is actually future-proofed, and will it meet the needs not just now, but for years to come in the future? And then just secondly, very interested to hear a bit more. I think there's a passing reference to the join-up between MSK services and the new elective orthopaedic centre, and I would just be keen to hear a little bit more about that.
Yeah.
Thanks.
Thank you. Rob, do you want to start off, and then I'll bring Joe in?
Yeah, just very briefly, absolutely, this is, I didn't declare it, but one of my previous roles was getting right first time, running the Royal National Orthopaedic Hospital for 12 years. This is a fundamental, 1 in 3 GP consultations, all the figures you've just described, the demographic time bomb, and people living in pain, quality of life. This is a fundamental issue. So acknowledge the importance of it. That is why we need an elective orthopaedic centre with the experts in it, and it's why we need a standardised approach to musculoskeletal pathways for people living in pain. And that's why, by giving a better offering and a more standardised offering, as that growth kicks in the population and the need kicks in, we've got means of supporting best practice, because neither are we going to have infinite supply of money and workforce, and therefore we have to have the most effective and efficient models of care, and this is following best practice, this is following all of those principles, because we won't have the workforce and the staff, and Joe alluded to how this is going to be provide more job satisfaction for people working in MSK, who can then provide a better service to patients and residents by having feeling better able to do the job by working out in the community multidisciplinary teams and through single points of access to triage patients in the most appropriate place in the pathway. So I'm hoping this is a future-proofing exercise for that future unmet demand that we face.
Thank you. Thank you for that, Joe.
Yeah, so I just want to say, I mean, I think I've come to present this in the lens of MSK, but actually, you know, we are working with primary care networks. We're working with local teams as well. I think my other hat I wear is also personalization, and people with long-term conditions as well. This is about that personalization. It is about that goal setting, and I think this best practice will then allow us to further help primary care networks develop that more holistic model, because it's not just about managing medicine, and that it's about, you know, people's emotional well-being. It's about how people are motivated to sort of, you know, wanting to or motivated to take care of themselves. So I think there's a lot of good models. There's a lot of good practice here that's relevant across.
Thank you very much for that. Natalia, please. Thank you.
Yeah. Thank you very much. And I do like the focus that you have in terms of that personalization agenda, which is really good. I just have a question about how can we better improve the joining at work. So at the moment, if somebody in Hammersmith has got an MSK issue and they need an X-ray,
yes,
they have got to go to Brent for an X-ray rather than having the X-ray done at Brent Hospital. So this initially in terms of access, how they get there as well.
Yeah, so diagnostics is definitely one of them as well, and one of, you know, as part of the development of this, as we work through, is to look at the diagnostic offer and how we're working across the North West London diagnostics. So, you know, I think for us it's there are different models everywhere, and I think one of the exciting opportunities about going out to procurement for this as well is that, you know, we've got, so in Westminster, I know some of the diagnostics are done right in the clinics as well. So, you know, there's definitely a lot of good practice that we can kind of benchmark between ourselves, but definitely, you know, that timeliness of diagnostics is key for us as a.
So is that something that will be brought about by this particular initiative, so that the process is as seamless as possible, as positive as possible for our residents?
Yes, because I think this is about trying to make sure that we're optimizing all of our use of diagnostics as well, and how we link into that program. But
Thank you. Let me bring Lucy in, please. Thank you, Joe.
Thank you.
Yeah.
I'm going to start. I've got a couple of questions for you. With just asking you, what will the service model mean for RBKC, which is a fully integrated community MSK pathway? Will a new standard model across NWL alter or reduce the service provision? And then this is actually sort of more, I suffer from MSK issues as I have multiple sclerosis, but one thing, sort of talking of my own hat, of experiencing the system, RBKC are leading the way, but for example, a year ago I tried to see a physiotherapist under my GP and I was told it was going to take 6 to 8 months. So this is what I really struggled to see. They're leading the way when that's not a very normal wait time for someone who would need to see someone, and that's just me knowing my own experience.
Yeah.
So if that is good in KNC, so what would be the case elsewhere?
Yeah, I think just a bit of a nuance to that as well. So the KNC model is, I think, as a service, is seen as leading the way. But I think there's a lot of issues that we're working through with KNC as well, because I work in the Borough as well. So we are going through some of these wait times and these discrepancies as well. By no means is it the best model, but actually in comparison and benchmarking across the other boroughs, it is actually the best model that we have now, but part of this work isn't to just replicate what we've got now in RBKC, but we are looking through some of those issues that you've got in terms of those wait times, because there are issues that that comes through us in terms of those wait times, that you shouldn't have to be waiting 6 to 8 months for a physiotherapist. So we do encourage people to raise these, because we do go through all of the patient complaints, and we do look at every case by case as well. So I'm very happy to kind of pick up with you outside as well, just because we need this feedback so that we can improve. And patient complaints are the one sort of key piece of information that we use. Yeah.
Just on that, how I mean, that 6 to 8 months is a long period. How do you improve that at a fast pace? And I don't know if the sort of equivalent of what the wait time is for other.
So I think it'd be really good for this community to be reassured. How is this new initiative, this service coming to Northwest London rather than NHS London dealing with it? How is this with Northwest London doing it going to make that positive experience right across our geography in the next 6 months, in the next 12 months?
Yeah. Sorry, I just want to clarify your question. So, how is Northwest London, by doing this rather than doing this as a London?
No. So this is now going to be the service that Northwest London is going to be dealing with, right?
Yeah.
So I just want to understand, how is this going to transform the service in the next 6 months, next 12 months, so that the experience that we're hearing from Lucy is perhaps a better experience?
Yeah. I think over this next sort of 12 months, I think part of this is we've got a strategy, because for the 5 boroughs we're going up for re-procurement, because that provision is expiring, which gives us this opportunity to look at that. I think then with the other boroughs that have existing provision, as an ICB, we have committed to implementing the new service offer now and addressing that as well. So, and I think the reason why it will change is because back to what Rob is saying, there's a standardisation now. There's clarity about what the service expectations are. It's completely varied at the moment, and we need to change that. But I do want to talk to you about your case, because we'll only learn from that, because what I don't understand is it a specialist physiotherapy? Is it something else, or is it, I'm very happy to kind of pick up with you.
Thank you for that, Joe. Rob, please.
Sorry, Rob.
I'll keep it brief. I think it builds on the theme that we had under ophthalmology. We need to present to you what our baseline access times are and how we're expecting to improve them going forward as a result of this. So
that's really helpful, Rob.
I think that's the recommendation.
Thank
To
you.
provide that. Of course, the idea would be to improve the access times across Northwest London and to not make any area worse.
Okay, thank you very much for that helpful interjection. Grateful to you. So let me bring now Marina, please. Thank you, Marina.
Thank you, Chair. So you have mentioned about sort of the high number of work absences due to MSK. Are there partnerships or collaborations planned with employment services or occupational health providers, and also community support to ensure that there is a holistic approach to MSK?
A good question. Thank you, Marina.
Yeah.
Joe?
Yeah, that's part of the work that we're trying to kick off to lead in terms of working through with the DWP, but also with local partners as well. We're still scoping that out. It's an area that we know we need to look at, and it's definitely part of our plan.
Thank you very much for that. Claire, please.
I just wanted to say that I'm working with a small group of people to look at a programme for people with functional disability. So it's particularly people with an interest, somebody who's got Parkinson's, but it would also cover things like MS and the whole issue that actually we know there will be deteriorations and fluctuations, and the need to build in a sort of anticipatory care component. So somebody who's got a diagnosis, they might be fine today, but in 2 weeks' time they might not be, or we know there's going to be, and how they themselves can take control of their own pathway. And then obviously you've got the whole other load of people who've got back pain that we know will probably resolve on its own, and then all sorts of other things. But I think it is particularly to have a sort of anticipatory care pathway for people with functional and long-term conditions that include functional disability.
Thank you very much.
Yeah.
Did you want to say?
Yeah, I apologise that Imran's not here because he knows this pathway inside out as well. But what I will do is I will take that back if that's okay, and make sure that is part and parcel. And I need to check with my colleagues as well because as a non-clinician as well, I won't be able to answer that.
Thank
properly.
you.
Yeah.
Thank you for that. Let me just come to Nick, and then I'll come to you. Nick, please. Thank you.
Thank you very much. I want to ask a question around the fifth bullet point on your front sheet, which is opportunity for productivity through detransactionalising MSK care in primary and community and on-ward referrals to acute care. First of all, what is transactionalising, apart from a terrible word to try and say, and what was the problem with it? And also, what is this new way, and how will it be better and how will it increase productivity? So just tell me a bit more about what that bullet point means.
Yeah, so I think this is coming back to the sort of, I think, depending on which borough you're in, there's different ways of getting into an MSK service. And I think what we're trying to do here is to try to have one door, really, like one place that triages this all, so that you're not having to bounce around different referrals or going to the GP first, then getting referred into a service, then getting referred on to secondary care. Where we can, we'd like to streamline that and really bring that together. And I guess it's a really clunky word, but there is a lot of transaction that is built into this, and there are some efficiencies. The efficiency comes from us kind of removing those barriers, and that's what we're trying to do. Sorry, Rob.
Thank you. Thank you for that, Joe.
Yeah.
Rob?
I think it's absolutely as Joe describes, just to bring it to life a bit. There's been a danger in MSK that everything is so overwhelmed that we use our whole clinical workforce to work on how to manage the waiting list and the triaging and the passing on to the next bit of the system, rather than using our clinical workforce to actually help with the solutions and providing clinical care for patients. And I think it's got to the point in some parts where such a complex referral mechanism and such a passing on to the next bit of the system that people are actually spending more time, and it is a clunky word, but on the transaction than they are on the treatment. And therefore, by doing this work, we can focus on the treatment and not the transaction, and that will provide a released clinical time and effort to treat our patients more effectively.
Thank you very much for that. Chetna, please.
Thank you. So the paper mentions about people from English is not their first language. How are they going to access the new model of care? And how are we going to make sure it's fit for them and they can access it? Particularly with actually doing the advice exercise on exercise and nutrition and follow-ups.
Yeah.
So I guess this is, there's a much more broader question to this point that Chetna makes. We talked about health inequalities, and I think, language barriers is, one of those factors. And I think, back of Marina's question, I think I would also be keen to understand from Sarah how we are going to be engaging or interacting with those key anchor partners as well. So both of you.
Yeah, I mean, I think this is why I'm saying we're in year one of this 5-year journey, because part of this work is to reach out, because I think we all know it's not just about translation, it's about lifestyle as well, and it's about understanding of how different communities work and how this. So this is part of the work that we're trying to do as part of phase 2 work is engagement work, and also going out to different communities. And I think you mentioned a group of that we need to go back out and kind of, because I don't think we have the answers, but we need to work to understand how this is going to best work for people. And obviously there's like I said, there's language barriers, but there's also other cultural barriers, there's also lifestyle barriers as well that we need to work through. Sorry.
Thank you, Joe. But Sarah, please.
So there's two aspects to this. There's sort of the engagement bit, and then there's sort of how we implement it. So from an engagement point of view, I think of some of the questions we got for ophthalmology. I'll just be very upfront and say no, it's absolutely not representative at this stage. What we have done in the phase 1 is we have we very much built on what we did from elective orthopaedic. So for elective orthopaedic, we spoke to a huge number of people across North West London who have experienced musculoskeletal services at various different points. We worked with the joint schools, we worked with groups like Versus Arthritis. We had therefore got a really great database of people who said, keep me informed. We have initially gone out to all of those people, the groups that we worked with before, and said, this is what we're doing around community MSK. We would appreciate your early thoughts. So that's sort of been phase one, is go out to some people that we know are already interested, are already engaged with what we're doing across the sector. Phase two is what Joe and I are sort of working on at the moment with the teams, which is looking at, okay, that's allowed us to look at some specific bits of detail. What do we need to do? Where do we need to explore this further? And both of those two phases are very much around procurement. Now, the bit that we really need to do, and that next stage, and I will probably reach out to a number of you who sort of like reference groups that you work with or sort of as individuals, is really going out and going, okay, we are now specifically talking about community services, so we will go out to those community services in the same way that with elective orthopaedic we sat in outpatients and we spoke to people who were there. We will go to where people are experiencing these services, but we will also go to the people who are not currently accessing these services. But when we go out and speak to, HealthWatch will always tell us that MSK is the biggest thing that they get told about. So we're working with HealthWatch, we're sort of saying, where are you hearing these things? Which groups do we go from? So we need to make sure that we are doing all of that work. And in terms of that language point, if we look at some of the programs we do, so if I take diabetes as an example, diabetes have done a huge amount of work recently looking at how do they make their lifestyle advice relevant to different communities. It is no good saying, hey, here's a great list of nice recipes. Well, if that's culturally not relevant and that you're like, well, I just wouldn't eat those kind of foods, you are not going to know how to make that lifestyle advice relevant to your lifestyle, even if we translate it into every language going. So it's about having that, it's about having a much broader approach to how we're doing it. It is not as simple as just going and engaging and then translating the materials. It's about thinking, well, what are we hearing from all these different groups? How do we support the clinical teams and the services with them making that advice best so that the behaviour change can actually happen, rather than just sort of like pushing a very kind of standard approach to things. So it's a long process, I guess is what I'm saying, and I think there's a lot of people in this room that can probably give us some very good guidance of making sure that we sort of do make sure that engagement is as strong as it can be.
Great, thank you very much indeed. Any final question, colleagues? Thank you. So before I bring this paper to close, let's see, apart from the natural recommendations which have flown from the replies, are there any particular specific recommendations that anybody wish to make to NHS colleagues? Yes, Ben, thank you.
So I think we captured the point around access times, but I really don't want us to lose the thread that my colleague Natalia talked about in terms of diagnostics. Obviously, in Ealing, we're going to have the new community diagnostic centre, and I just want to ensure that there's a link up and that's all properly considered. So I think that lends itself well to a recommendation.
Thank you very much for that, Ben. And any other recommendations, colleagues? Okay, thank you very much. So we bring this paper to close, and then we come to the paper next, which is about our work program. And I know one or two colleagues have very helpfully contributed towards further thoughts, which I am very grateful to be taking it forward. But are there any quick comments? You don't particularly need to make them here. Very happy for you to take up with me offline, as well as, of course, here as well. And I don't know if any of the NHS colleagues in the room, including Rob, Rob, you want to make any comments, then I will be happy to take those comments. If there aren't any comments, then I will take that as tabled. But of course, this is a working document and evolving document. So, very happy to reflect your thoughts as we move forward through the year. And of course, do get hold of us anytime for that. The next paper then we look at is the recommendations tracker, and grateful to George for putting that together for us. I think it's a good paper to have. It's a good tracker to have, so we know where we are on the recommendations that we are making, and equally I think valuable to NHS colleagues to know what we are missing from them. So I hope, Rob, you and your team will equally find this helpful going forward.
Very helpful, thank you.
Thank you. Are there any quick observations on that? Any thoughts about how to improve it or how to make it even more user-friendly for us? Anybody? Thank you very much. If there is... yes, Natalia.
I'm assuming we're moving now to any other...
Indeed.
Thank you so much, Chair. I just wanted to express my gratitude for the nomination and election of Vice Chair. Thank you so much. I'm looking forward to supporting you and working in collaboration with other partners for the benefit of all the residents that we represent. Thank you very much.
Absolutely. And I think, as Bob was saying, residents are why we are here. So thank you very much for that very positive contribution. Grateful to you. Any other business? Anybody? Thank you very much. So I do have one very tiny piece of update to give, but unfortunately it's not of good news. It's it's somewhat incredibly sad personally for me, and that is to say that the chap sitting next to me on my right is going elsewhere. He has just been promoted to a much, if you can't have any bigger role than scrutiny officer, he's been promoted to a much bigger role, and this is his last meeting, and I personally am going to be missing his incredible support that he has given to me as the chair of this committee, and indeed to all of us here. You know me, the local scrutiny officers from all the 9 boroughs are very, very incredibly supportive, and I value each of those respective contributions immensely. But I think particular thanks to George this morning for all the work that he has put up with and supported over the past 12 months. So we will certainly miss you. And we wish you very best in your new role. But for the time being, once again, thank you very much indeed. Okay, with that, I think I will bring this meeting to close. It's just 12 o'clock, and the time to take a pause until we meet next time. Thank you very much.
Thank you.
Thank you, Rob.